Thank you, Vijay and Sandeep, and thank the organizers. But as you said, it's not over until it is over. And with the expanding use, you can see that complications can be in various kinds of situations. And I will cover the complications depending upon access site related to the coronaries, so on and so forth. You can see that patients who have more comorbidities, patients who are older, the experience of the operator, the presence of peripheral vascular disease, tortuous vessels, so on and so forth, increase the risk of complications. Let's look at the multiple complications that you can see from the femoral site, retroperitoneal hematomas. I can tell you one of the most dramatic and ghastly complications where you can lose a life after a very good angioplasty or after any other good procedure is a retroperitoneal hematoma. This is one in which you will see a sudden drop in blood pressure when everything else is going absolutely fine. Then you could have AV fistulas, you could have large hematomas and pseudoaneurysms. Here was a case, a successful PCI done by a colleague of mine, came out very nicely, and immediately after that they had a drop in blood pressure. And you can see that from a very small twig on the side, there was a continuous bleeding that was occurring, pushed the bladder to one side. Such was the size of the hematoma. They fortunately recognized it quickly, went across from the other groin, and then were able to seal it. You can do that by putting coils. You can keep a balloon sometimes over there for some time, or you could even put a covered stent. But you must be aware of this particular thing, and this can sometimes create problems for you if you don't take rest. You don't take the appropriate measures. This is how you need to target the puncture. I think all of us are doing it these days, looking at the femoral head. Don't puncture too high, because that's one of the causes for these ghastly complications. The radial route, as most of us, or a lot of us have changed over to, clearly should be the route of choice unless you have certain problems with it. And one of the areas that we now cover is the fact that you reduce complications quite significantly. In fact, in the situation of acute coronary syndromes, your absolute risk reduction is close to 2%. And I think most people who come to you with an acute coronary syndrome should be given the choice of a radial route. Arteriovenous fistulas, seen more frequently in the femoral site, but we've had one or two in the radial. The incidence is extremely low, but you must remember that it can be there and may lead to what is called, sometimes you may have the compartment syndrome. Of the whole lot of complications through the radial route, I would say the one that is the most difficult, where the patient may even lose his hand, is the compartment syndrome. When it occurs, you will get compromise of the neurovascular bundle. And therefore, you must be very vigilant that if it happens, then you must call in your surgeon quickly. If other measures like raising the hand, tying a crepe bandage do not work, you must immediately create a fasciotomy so that you can save the hand. There have been one or two patients outside of our center who have had and lost their hand in the early days of radial. So this is a complication that should be immediately taken care of. Pseudoaneurysms can occur. Femoral site is more common than the radial site. Very often, just the compression with a probe can seal this. Sometimes patients need to go to surgery. So this is one where we can show you that. It's basically the arterial thrombus, which used to be a problem for us in the previous days, 20 years back, when you used to use the Seldinger needle over and over again. Many of our surgeons had to come in, but you must remember that can still happen in the lower extremity. Radial spasm has almost become a thing of the past with the wonderful sheaths that we have, but can occur in some situations. You must use adequate coronary dilators, and you can see that you can eliminate it in most cases. This was a patient who had a very rare complication. After a procedure was done, there was a clavicular hematoma. Now, one of the ideas that I would like to give most people is that when you're doing radial approach, please remember, watch the guide wire carefully as far as possible. Very often we need to use a Terumo type guide wire, slippery one, but that can go and nick one of the vessels. And this was a large hematoma that formed below the pectoralis. And you can see from one of our scans that a small blood vessel happened to be involved, causing a pseudoaneurysm. Went ahead, but fortunately, during that time, the vessel had thrombosed off by itself, and the repeat Doppler showed us that and that could be attended to without going through any kind of coil or things like that. So these are some of the results that can happen. They're some of the rare complications that can happen. Now, one of the things which most of us forget, I think, you must be aware of this. We had a patient who developed a very large bleed in the brain on the day after an angiogram, and this can sometimes happen because of the fact that their blood pressures go up very severely. They're very, very tense, and we thought it was an infarct because of this thing, but it turned out to be a bleed. You must pay attention to all your procedures. Arrhythmias is another one that can be seen, especially you can get patients who have had a good angioplasty, but may come up with a VTAC, VFib, so on and so forth. The coronary complications I will go through very quickly. You may have done a wonderful job, but you may have dissected one of the vessels as you come out or as you enter. You may not know about it. Retrograde aortic dissections are something else that you must look at that could happen during a so-called successful angioplasty. Stent edge dissections may be missed and may cause thrombosis later on. This is one of the other things that you must remember, that after successful angioplasty, you may be called back later to attend to a patient. Stent thrombosis has already been spoken about. I think it's become much less, but all of you know that when it happens, it can be catastrophic. And I don't need to go into the management of stent thrombosis, already spoken about. And so it's one of the things which, we can use sometimes IVUS to see what has happened, whether the expansion of the stent was proper or not, and so on and so forth. I will, not cover, most of these things have already been covered, so I don't need to cover stent thrombosis in a big way. How could you minimize the PCI complications? I think selection of patient, selection of the material, excellent knowledge about the equipment, know your limitations, as was pointed out by our chairpersons earlier. Always maintain the highest level of concentration, especially when you are starting to do all these new procedures with imaging. I think maintaining ACT is very important. Check every half an hour. Learn from one another's mistakes and misfortunes. Thank you very much.